gave me the task today of talking about AI or artificial intelligence in cardiothoracic surgery. So, it's been huge developments recently. So I thought appropriately, I titled it AI and CT Surgery, The Future is Now. I have no disclosures. So just a brief overview of what we'll be talking about today. Oh, and by the way, feel free to interrupt me at any point if anybody has any questions, or drop it in the chat. We can answer them at the end of the talk as well. So for the overview today, we're going to do a brief overview of AI and machine learning, and then I'll dive into how it's currently used in CT surgery, mainly predicting outcomes in different subspecialties of CT surgery. Then we'll take a look at how it's used in the interdisciplinary CTS team and what the future holds for AI in cardiac surgery. We'll talk about a few drawbacks of the technology, and then at the end, if we have to, we can talk about tips and advice for the match for those who are either going through it right now or coming up in the near future. So first, as a brief overview, so what we will not be discussing. So the algorithms and concepts behind machine learning and AI are incredibly complex. People dedicate their entire careers to this. What I will focus on is real world applications of this in cardiac surgery from a clinician perspective, and not the algorithm, not these complex algorithms. So AI, or artificial intelligence, is a broad term, but it's defined as adding more cognitive ability to machines in order to mimic human behavior. Machine learning is a subset of this that focuses on algorithms that learns from the data that traditional statistics can't account for. This is then used to generate predictions or decisions. And then even more complex is deep learning, which is more complex than machine learning. And this involves the utilization of artificial neural networks with representation learning. In machine learning, data is input into a model which labels said data, identifies features, then generates an output. To put this into more, to simplify this, for example, you can take a picture of a coronary artery as an input, label it as coronaries, and then specific features can be identified. For example, coronary plaques, to finally output it as either symptomatic or asymptomatic classification based on the images, which the computer model can then learn from. So with that, we'll dive into how we currently use AI in cardiac surgery in predicting outcomes. The hope is to uncover these relationships we didn't even anticipate, and improve the predictability of the data set. One such use comes from a recent study that looked at looking at comparing machine learning model with Euroscore and predicting mortality after elective cardiac surgery. So first, as a background for everybody who isn't familiar with the Euroscore, it's one of the major scoring tools used to predict postoperative mortality during hospital stay through the collection of preoperative variables shown here. Basically, you can go in and check all these boxes based on patient demographics and related factors, and it'll give you a percent predicted mortality based on thousands of patients in their data set. So this study came from a group out of France with about 6,500 patients having elective cardiac surgery with cardiopulmonary bypass. Those patients had a mean Euroscore of 3.7%. However, 6.3% of their patients died. Thus, the predictive model underpredicted some patients. So in their machine learning group, it had previously shown that assembling the results of different machine learning algorithms can outperform any single base learner. Due to this, they performed what's called a greedy ensemble, or fancy for a weighted sum, of the probabilities attained with each of the 4 machine learning algorithms, which they called the machine learning model, shown here as a red line. Analyzing this receiver operating curve, the curve tells us how good the model can distinguish between 2 things. The larger the area under the curve, the better the model is at distinguishing positive and negative values. The closer to the straight gray line, the more that the predictions become almost random. Here, the area under the curve for the machine learning model, the red line, was significantly higher than the Euroscore prediction shown in the blue and black lines. Thus, they concluded that the machine learning model is more accurate in predicting mortality after elective cardiac surgery. And it may be very useful in decision-making involving very old patients, or to help choose between transcatheter or surgical aortic valve replacement, where there is currently no predictive model that includes both modalities. Similar work has been done to predict AKI, or acute renal injury after cardiac surgery. This group tested several different machine learning techniques versus traditional logistic regression analysis. Looking at the area under the curve, many of the machine learning models shown here on the top have an area under the curve closer to 1, or a better predictive model, versus many of the logistic regressions or traditional stats analysis are closer to 0.5, which is no better than guessing. That graph was then shown here as a figure. This figure is a little busy, but if you follow it, many of the lines hovering near the green straight line towards the right are the logistic regression data. Again, having better predictive tools in this case may help you stratify patients to operate on, but it also may give you more informed idea of the risk of surgery to individual patients, and then you can better inform them of their individualized risks. For any budding pediatricians or congenital surgeons, AI has even broken into congenital heart surgery to estimate the risk. For many years, the risk adjustment of congenital heart surgery has been taken as the gold standard to measure risk. It's based on the categorization of surgical interventions and is used to compare mortality across hospitals. The diseases are assigned to six risk categories, with 6 being the most complex and 1 being the least complex. As you can see here, an ASD would be a low risk procedure, risk category 1, and the least complex. And then a Norwood is typically done in the first 2 weeks of life and where we reconstruct the PA and the aorta for hypoplastic left heart syndrome within its appropriately categorized category risk 6. However, as you can imagine, having a risk score based on only the procedure itself can have inherent flaws. A healthy 14-year-old undergoing a ASD repair is very different than a sick, malnourished 2-year-old and undergoing the same procedure and having failure to thrive. Thus, machine learning could have a potential benefit here. So out of Columbia, using over 2,400 cases, this paper presented a decision support system to classify the risk of pediatric cardiac surgery into 3 different categories: low, medium, and high risk. In order to get the best accuracy, they assessed 4 different machine learning algorithms and applied cross-validation to assess the generalization of the classification. Evaluation of accuracy was similar among multi-layer perception and radial basis function, shown here in red, with 99 and 95% accuracy respectively. This classification can be useful to predict mortality prior to surgery using pre-surgical variables, but it also can be used to anticipate mortality and associated risks after surgery with the use of post-surgical variables. Something that interests me is heart failure. And there was a recent abstract just recently at one of the major conferences looking at machine learning analysis of pre-implantation risk factors for right heart failure after LVAD implantation. Right heart failure is a dreaded complication after LVAD implantation and is associated with worse long-term outcomes. However, until this point, we've only looked at individual risk factors as discrete predictors of RV failure. What this machine learning algorithm revealed is the importance of pre-implantation risk factors in their non-linear interacting relationships with right heart failure after LVAD implantation. Thus, we're learning that different variables might have different weight based on their numbers and potentially represent a different risk stratification in even different patients. Moving on to in the aortic literature, the Yale group has been studying aortic aneurysms for decades and has come up with a standard triage algorithm used throughout the world. Their core algorithm is in its simplicity: surgery for larger symptomatic aneurysms. This means aneurysms greater than 5 centimeters, you recommend surgery. For those 4 to 5 centimeters, if patients are symptomatic, they also get surgery. Otherwise, it's just medical management. On paper, this seems great. For patients triaged to medical management did well with a low rate of aortic events, and patients triaged to surgery who could not undergo the operation for a variety of reasons did poorly, with many aortic events and a high mortality. This triage mechanism did exactly what it needed to do, weeding out patients with high aortic risk who need surgical intervention to keep them safe. However, they aren't looking at individualized patients. Their algorithm only accounts for the diameter of the aorta. Taking a closer look at their data, males have a lower incidence of aortic events, and those with CKD have a much higher risk of an event. So I bring up the question, would you offer surgery to these patients? A 75-year-old male with CKD4 and an aortic diameter of 5.1. Based on their algorithm, you would have to offer them this surgery, but this patient has other risk factors that are not accounted for in their algorithm. Or this second patient who's a 40-year-old female who's relatively small, healthy with an aortic diameter of 4.8. This is someone who I might offer surgery on, but based on their algorithm, she wouldn't meet qualifications for surgery. And then they don't take into account when we do cardiac surgery, it has inherent mortality risks in of itself. So this is where machine learning can really help to provide a more accurate risk assessment for these patients by incorporating more variables and learning over time what patients could benefit from surgery. And then with the popularity of minimally invasive or percutaneous interventions, direct visual valve assessment has become limited or impossible. ECHO, with mitral valve quantification, has an assumed importance in clinical relevance. Variability in user measurements can result in more operative time, but potentially incorrectly sizing a valve, which could be deadly. This study looked at using automated analysis built into an intra-op TEE to make the valve measurements shown here on the right. And the picture shown on the left is just one of the techniques we do for minimally invasive mitral surgery, where we do a small left anterior thoracotomy, or I'm sorry, small right anterior thoracotomy. They measured the end systolic frame, or the last frame before the mitral valve opens. And what they did was they did this for 4 patients with 3 different anesthesiologists. And what you can see here is that the automated mitral annulus calculation is almost identical between users. And from this, they were able to conclude that using automated analysis, it is possible to obtain results with good reproducibility, which only requires minimal user intervention. This is still early in its adoption, but I find it fascinating. So moving on beyond predicting outcomes, AI has a really important role in the interdisciplinary CTS team. CT surgery is a perfect example of how AI can be used to support surgical care. The OR and our ICUs are a high risk, high stakes environment with multiple different specialized professionals interacting with one another. Here you can see 2 pictures of our team at Montefiore. The picture on the left was a recent aortic valve replacement that we happened to catch the left main. We had to emergently crash on the bypass. You can see our surgical team here working to go back on the bypass. Our PA team down here getting vein in case we needed to do an emergent coronary artery bypass. The perfusion teams in the back, you can't see them, but they're preparing a new circuit. And the anesthesia team here is using the TEE and looking at the heart to form an assessment of the valve. Here on the right is a different scenario where we have basically all the same teams, including our ICU team, trying to wean an ECMO device and using a TEE probe in the ICU and all working together closely. These teams perform tasks in a coordinated way, requiring cognitive abilities that are beyond each individual team member's performance. Existing AI systems are able to collect, process, and make sense of information gathered in the OR. However, an important requirement for all these systems is the ability to understand and adapt their algorithms based on real-time contextual information, enabling them to provide context-aware assistance. One example of this in the literature is the interaction between the surgeon and the perfusionist. Here was a study that looked at 2 expert perfusionists who made about 150 decisions regarding low oxygen delivery to the body while on cardiopulmonary bypass. This is a simulation in which this is a real life critical situation that requires prompt action by the perfusionist in interaction with the surgeon. The options listed here are the typical options available to the perfusionist to increase oxygen delivery to the tissue. The AI system decisions were tested against the decisions made by the perfusionist. And overall, the machine learning approach was able to achieve an accuracy of almost 78% in predicting the perfusionist actions. Again, this is only a small study but it represents the potential of machine learning being able to interact in the OR and act as a safety mechanism to our team. So where do we go in the future? I think AI has a huge implication in the OR. Here's one of our fellows sewing in a heart during a transplant with our attending just watching. The current gold standard of assessing intraoperative performance is by observing and rating it by experts or our attendings. Although these methods are widely used, there are many limitations regarding to the inherent subjectivity of these tools, suboptimal interaction, suboptimal user ratings, and limited reproducibility. The use of AI and computer vision offers a promising opportunity to automate, standardize, and scale performance assessment in surgery. Additionally, what if we could leverage video for 1,000 heart transplants where a robot is watching and learning the surgeons operate? We might then be able to identify when a risky maneuver is being performed. For example, if the PA is being torqued and too much pressure is being applied to the vessel, and there could be a warning flashed. This concept is very similar to robotic cars where one has a near miss on a specific turn, and that info can be disseminated to all other robotic cars in the world to not have that happen again. This concept can also be used with trainees in robotic cases, where the robot could have the ability to stop and have an attending override a warning if necessary, if the trainee is making a dangerous maneuver. This could also then prompt further autonomy, or by giving attendings more reassurance if they don't see something wrong and the robot also doesn't see any wrong maneuvers. However, with all new technology, we have to ask ourselves, what is the threshold of accuracy? Similar to cars, there will likely be mistakes, and we will need to manage the public's expectation and define what the threshold of an acceptable rate of failure is. What about using machine learning in heart transplants? This is a transplant shown here on the right, is a transplant I recently did, where we went out to the donor hospital and put the heart on a pump machine. And we currently use this heart in a box for certain transplants, and it beats the entire time that we travel, and we treat it like it's in the body. But what if we can put together an algorithm that can take into account certain features of the heart, like the size, age of the donor, et cetera, in order to better optimize, individualize the hemodynamics while we're in transit and it's on pump, to minimize any potential dysfunction once it's in the recipient. And then in terms of screening, this is something that's right around the corner for the thoracic surgeons. From the oncology perspective, machine learning, it will hopefully be able to read CT scans for lung cancer. It's already being done with mammograms. Machine learning has been shown to read up to 500 images a minute. And there's thought that they're more accurate to radiologists. Now, I don't mean to, any budding radiologists out there, I don't mean to question what you're going into. It's just, how are we going to be able to utilize these tools in your future jobs? Shown here is a CT scan that shows a pulmonary nodule here on the right, in which most people know the CT scan because it was used in the study. It shows the pulmonary nodule here on the right. Not sure how many of you also noticed the gorilla here on the left, but 20 out of 24 radiologists didn't notice this gorilla here on the left. So this is something that machine learning might be able to be involved with and pick up on things that radiologists aren't noticing in scans. So that, again, this begs the question: will radiologists be out of business, and will machine learning be replacing or assisting? I think my thought is it'll be more on the assisting side, and radiologists will have to step in and apply their expert ability. But this could provide a good way to screen away the easy cases, and to provide a way of allowing radiologists to focus on the more complex cases. And it also provides a way that we can provide screening to underserved areas. This technology, similar technology, is already being used, where one ICU doctor can manage multiple ICUs in different hospitals. Now for potential drawbacks. So the biggest drawback, which skeptics report, is the black box. We have limited insight on how these algorithms are actually making their predictions and forming their neuronal synapses. There's also inherent that these machine learning algorithms could have bias against race, gender, HIV status. We don't know how these machine sometimes decisions, and we have to make sure that they're not biasing against certain groups. And then it's only as good as the data present. We need robust data sets in order to, and accurate data sets in order for these machines to learn properly. And they are still subject to outliers. So with all this, we need to recognize and tackle the problem with robust testing as we move forward. I leave you with this. Instead of artificial intelligence, I recently heard someone call it augmented intelligence. I like thinking of AI and machine learning this way, since it's not going to take over the job of a doctor, but these models will bring in more data that we can handle and allow us to use it in real time. It'll just be another data to improve patient outcomes. And with that, I'd like to thank everybody for listening. Hopefully you were able to learn something about AI and cardiac surgery, or just become fascinated with cardiac surgery. I could talk about it all day. And happy to talk offline with anybody. You can reach me my email's here, my phone number. You can text me or reach me on Twitter, and we'd be happy to talk to anybody about this. And with that, I'd open it up to questions.
Thank you for the wonderful presentation. Any questions from the audience?
Yeah, I do have a question, Gabriel. Dr. Ferrell, thank you so much for your presentation. I know you mentioned towards the end that one of the challenges in being able to sort of develop and implement machine learning based sort of thought processes is related to needing to have the right data to be able to develop those insights. So I noticed, I don't have too much background in this context, but I noticed that one of the scores that you mentioned was the Euro score. And I know that data centralization in healthcare is something that's much more common in Europe and in other countries. So how is that something that you see affecting our ability to implement these types of insights in cardiac surgery or otherwise in the United States? And are there sort of workarounds, or do we have to rely on models from other countries in order to actually be able to harness those insights ourselves?
Yeah, that's a great question, and something that I think the whole as a society in the States we're focusing on. There's been a huge push recently. I'm not sure if you're familiar with the STS database, but that's a centralized database that most cardiac surgery programs buy into, and they have to report their outcomes. And we're judged on a national scale based on outcomes of 4 or 5 procedures. Still not all encompassing, but I think that's a start, because that's probably one of our most robust data sets that we have as a society. As you mentioned, Europe is definitely ahead on data decentralization, and I think as you witness here, you go between Georgetown, VHC, all these hospitals have different EMRs even. So trying to get all these people to come together and to get centralized data is a huge obstacle to overcome. But I think it's being addressed on the societal level of the STS and the AATS, and they're trying to have it become a standard that all programs buy into, reporting their data, not only for AI and machine learning, but it's important to keep each other accountable for our outcomes, and to report and to see how we can grow as a profession as well. So the point you raise is valid, and something that's actively being addressed.
Thank you.
We also have a question in the chat. I can read the question actually. So it's from Ryan. Thus far in your training, have you been exposed to any of the technologies you mentioned? If so, can you hit on any personal experiences with these scores or technologies?
Let me think of any of the technologies. So in terms of heart transplant, it's something that we are actively looking at in terms of trying to automate the decision-making capacity of when the heart's on the box. And that's something that as an institution that we are looking at, along with other institutions in a national study. In terms of the CT, we're located in New York City, and the CT guided, the automated CT scanning is something that we're also actively investigating as well. And that's something that we're hoping to implement into our, not as a replacement for radiologists reading the scan, but more so as if a scan is flagged as potentially having a pulmonary nodule, then being directed to either the thoracic surgeons or radiologists for further review, so that we don't lose the vulnerable populations to follow up. So those are the 2 main ones. I would say where things could grow and expand is in the OR and feedback. I think if we're able to develop a feedback system that's more automated, it'll allow trainees and attendings alike to grow their skills over time.
I love the use of augmented intelligence in the sense that it will augment instead of replacing us, because I agree some people are worried that AI will take over our jobs. Although that might be true in some of other fields, your presentation today touched on many examples where AI makes our jobs more efficient and accurate. But can you think of any specialties? I know you mentioned radiology, where AI will most likely replace physicians.
Hard to say. I don't think I think the concern is radiology, but even then, I don't think they'll ever replace. I think the expertise of a physician and the training that we go through, can never be replaced by a machine algorithm. There's going to always be cases that are needed to be reviewed, and with the evolution of neoadjuvant treatments in oncology and minimally invasive surgical options, it takes a team approach now for a lot of these patients to come to a conclusion of, well, this is the appropriate treatment, and the radiologists are a large part of that team. So I don't see it replacing ever. I see it more as an assistive thing. Just as we're growing and developing larger and larger data sets, it's just going to be another point that we take into account, and it might provide, and hopefully eventually it makes our lives easier as well, that it does some of the calculations and it guides patients to the right therapies sooner, so that we can then focus on patient care more so than the hassles of the logistics of getting patients there.
Okay. And also I had a quick question about, so I know that the heart can survive for 4 hours from the moment of cross clamping. Does that apply to the example of the heart in an artificial pump that you showed us, the picture? Is it common practice, or like, can you give us a little more detail?
Sure. Yeah, I can go back to that. So the heart in the box. So basically, we reperfuse it like it's in the body. The 4-hour time mark applies to cold preservation, if we were to do it that way, but we're able to extend the periods using the heart in the box. We use these for high-risk donors, DCD donors, which is a whole other topic of conversation. Or if we get offers that are further than what we think we can get the heart back and implanted in 4 hours. So this is, we're on the East Coast. This has allowed us to go to the Midwest or Plains and take hearts back from there as well. So this is a development technology that Transmedics has put out, and it's fascinating. If you have any interest in it, there's some good data out there, fascinating papers on it, and lucky enough to be part of some of the early trials of it. So.
Yeah, that is fascinating. Thank you. We also have one last question.
Sure.
So could you maybe talk about your background and how you got started in AI, and how med students with no background can begin to get involved? And how do I even get started, since this just feels so new and daunting for someone with no background whatsoever?
Sure. So AI is a developing field. It's something that I think finding the right mentor who's interested in it will help guide you and teach you the basics. It's easy to get lost in the weeds. As you can see, there's complex algorithms behind it. So avenues that you can take more of the clinician perspective, where you have people assisting you with the equation part of it and developing the systems, and you're more applying it. Or you could be, if you like the development and the systems part of it, you could take that approach as well. But I would say for people who have no experience, Georgetown's lucky enough to, I think I was talking about this earlier, but Cytel and there's a whole department the human factors department that deals with artificial intelligence and machine learning, and trying to ramp that up at Georgetown. So that they're great people to reach out to. I worked with them when I was a med student at Georgetown, doing some projects on sepsis. And then, if you have a specific field that you're interested in, there's usually, there's probably at least one expert that I would say at Georgetown in the field that you can reach out to. For cardiac surgery, I'm not sure that this is such a new concept of cardiac surgery that I can't even say there's any experts in cardiac surgery yet. Other fields such as radiology, general surgery, and other fields are much more developed than we are. So if you're interested in cardiac surgery, it's going to be a little harder, but I would say in the other surgical fields, you might have an easier time finding someone who's at least interested in machine learning.
All right, that was our last question. So thank you so much, and we'll move on to the raffle now.
Right. You want me to talk about the, I'm not sure how many general surgery people are applying. You may breeze through my thoughts on this.
Oh, yeah, please do.
Okay. So just for anybody applying this year or just some thoughts that I've had since I've gone through it now and experienced it. I6 obviously is extremely competitive, and general surgery is as well. But That said, step exams are just one part of your application. I know step one for many people now is pass fail. That I think for most people that are applying this year's pass fail. So there might be more emphasis on step two, but again, it's something that, try not to, it's hard not to stress about it. I was in your shoes just a few years ago, but a number doesn't make you a good doctor. I know plenty of people who scored all over the place on step and are now fabulous residents and great residency. So don't let yourself get caught up on that. For letters of recommendation, definitely ask early. For those who are applying next year, I would start looking into those soon. But by the holidays is a great time to reach out to people. And then if you are anticipating needing a letter in August or September, asking at the start of the rotation, even though it's a little awkward, people expect that. It's better to ask early. That way, you can always follow up with people later, and instead of asking too late and saying, "Hey, I need a letter 2 weeks," and you realize that your mentor is going on vacation, for one of those weeks, you'll get a better letter. That said, you don't need the president of a certain society letter. You want someone who can, be personal and describe you well. Now that I'm on the other side of it, and we have residents sit on our program committee applications. What people want to see is that you're a well-rounded individual, and they don't. It's very clear when people write letters who don't know you, or you rotated with them once, but you want the letter because of their name. Extracurriculars, I probably can skip. Everybody at Georgetown is involved with a million different clubs. Research, now that step one is gone, people are recommending getting involved earlier with research. Just find mentors that you get along with, and that you can form relationships with throughout your time at Georgetown. Again, it doesn't have to be groundbreaking research. You're going to always hear about people who are published in the New England Journal or larger journals, but your research doesn't have to be groundbreaking. It's just they want to see that you're invested in a project, that you can take it from start to finish and talk intelligently about it. And I think that got me a lot further than saying, "Hey, I'm the 6th author on this New England Journal paper." Personal statements, think early. I think this is something that's underestimated. I started writing mine like 6 months in advance, and I would just add a couple sentences when I thought of different things. And then by August, it was easy to wrap up and put together. Reach out to current residents, get an idea of what the culture's like at different programs. I think that's one of the biggest things to help you identify if it's a program that you want to apply to. Once you apply, all the programs are going to sound the same. Every program meets their case numbers. If you're going into a surgical subspecialty, every program has mentorship, research, but you really want to see if it's a culture that you identify with and can get along with. That goes so much farther than saying you went to the #1 program just because you wanted to. And then lastly, in your 3rd and 4th years, I would say attend meetings. I know Georgetown has some money put aside if you're presenting, but you can also, if you want to go to a meeting that you're not presenting at, you can look for scholarships from the meeting. The STS and the AATS are two big thoracic societies, and they offer scholarships like member for a day for students to go travel and attend the meeting, and that's a great way to network. And they can pair you with leaders of the field and help you with your applications in the future. I know many people who applied I6 went through this process, and it's incredible that they pair you with somebody Tyrone David or leaders who you just wouldn't be able to talk to otherwise. So I think it's a great way to get your foot in the door, and it also allows you to see if it's a field that you kind of confirm or confirm to you if you actually want to pursue that field. So just a few thoughts of mine. Feel free to reach out if you have any questions. That's it.
Thank you. Awesome. Does anyone have any other questions regarding the advice you just gave us?